Vaidya sir, it is almost 5. With your permission, should I?
Yeah, please. Right. Please go ahead.
So good evening and warm welcome to all the faculty members and all the delegates who are there on this Sunday evening. I am Dr. Amit Borse and I'm head of medical marketing initiatives at MCure Pharmaceuticals Limited. MCure is a pioneer in the field of gynecology and IVF. I represent the division called IVA. IVA is related to IVF brands and we are a preferred partner in IVF therapy. Materna is our prime brand and is an epitome of quality and success. Today, we are very thankful again for this 4th series, which have been very successful with interviews of international icons of IVF. Firstly, I would like to give a lot of thanks to Dr. Rajan Vaidya sir for coming up with this initiative, which has helped us to highlight international trends in IVF and to share the good practices. I would also like to thank Dr. Meenakshi Chaudhary ma'am to accept to be a co-host and help us towards making this series successful. Before going ahead, may I ask Mr. Nikhil Mehra to say a few words?
Yeah, sure. Thank you, Dr. Amit. So very warm good evening to all the viewers who are watching from India, and a warm good morning and good afternoon to all the viewers who are watching from other part of the world. I am Nikhil Mehra. I am heading a sales of Amcure Iowa division. Let me tell you a small glimpse about Amcure. So Amcure, we are at Amcure are the leading pharmaceutical companies in India, having present at over 70 countries worldwide. When we talk about India, we are the number 1 company in the field of gynecologicals and the most preferred partner in the field of infertility related medicines. Thank you, Professor Anderson and Dr. Vaidya, Dr. Chaudhary for being a part of this event today. And thanks to all the viewers and delegates out over here. Over to you, Dr. Amit. Thank you.
Thank you so much, Nikhil Mehra sir. Before I go ahead, I'd like to introduce our host, Dr. Rajan Vaidya sir. Although in India, he does not require any introduction, just for a matter of sake, he's an honorary consultant at Department of Assisted Reproduction, Naurozji Wadia IVF Center, Parel. I'd also like to introduce our co-host, Dr. Meenakshi Chaudhary ma'am. She's a senior consultant in reproductive medicine, Newcastle Fertility Center, NHS Foundation Trust, UK. May I now give over the session to Dr. Rajan Vaidya sir. Sir.
Yeah. Thank you, Dr. Amit. Good evening to our viewers in India. Good afternoon to those in the United Kingdom and Europe. And very early morning to those in the United States, and hello to those in the other parts of the world. It gives me immense pleasure to inform that our ongoing series of educational webinars of interviews with international icons of IVF is being well attended, and I'm told that we have more than 3,000 registrations already till some time ago. Our today's topic, that is role of ovarian tissue cryopreservation for fertility preservation in girls and young women, is a very novel topic, as ovarian tissue cryopreservation is being widely applied as a method of fertility preservation in girls and young women afflicted with cancers. More than 130 live births have been successfully reported so far from various parts of the world after ovarian tissue cryopreservation and its subsequent autotransplantation. To tell us more about ovarian tissue cryopreservation and its various applications, we have a very renowned, eminent faculty who has done a lot of original work in this field. Professor Dr. Richard Anderson, Professor and Head Section of Obstetrics and Gynecology and Deputy Director, Center for Reproductive Health, University of Edinburgh, United Kingdom. I request Dr. Meenakshi to please introduce Professor Dr. Richard Anderson to our viewers. Dr. Meenakshi, please go ahead.
Thank you. Thank you so much. It's my pleasure and welcome everybody. It's my pleasure to introduce Professor Richard Anderson, who needs no introduction in UK or worldwide because he's a known fertility stalwart. Absolutely. As Dr. Rajan Vaidya did mention that he's a professor of clinical reproductive sciences. He is based at University of Edinburgh, which is in Scotland, the beautiful part of UK. And he has main interest in fertility preservation, but he's an expert in all aspects of fertility as such. He has been associated with ASHRAE for a long time. He's the past coordinator of ASHRAE Special Interest Group in fertility preservation, and also represents ASHRAE Executive Committee and HFEA Scientific and Clinical Advances Advisory Committee as well. As you can see behind me, there is a clock, which is not a biological clock, but I would hand over to Professor Richard Anderson to start the topic on fertility preservation, which is to sort of get hold of this biological clock for future, for women and girls who need that. Over to you, Professor Richard Anderson. Thank you.
Well, thanks very much, Meena, for that nice introduction, and thanks for the organisers for the invitation and the opportunity to discuss this topic with so many of you. It's a great thing to be able to do this with such a broad and large audience. So I'm going to discuss some issues regarding fertility preservation, and particularly focus on ovarian tissue rather than the other methods of fertility preservation, but they might just get touched on as we go along. So, of course, the background to this is the developments in oncology that have led to so much better survival for so many more of our patients. And I like to show this slide because breast cancer is the most common cancer in reproductively aged women. And you can see here the really quite dramatic change in mortality from breast cancer that occurred. And this is specifically UK data, but it's worldwide, with the recognition that chemotherapy was a core part of the treatment, even for early stage breast cancer. And that led to dramatic improvements in survival over recent, actually now several decades. But this, of course, comes at a price. And in breast cancer, and indeed in many other cancers, the chances of women going on to have a pregnancy and a baby thereafter is really quite markedly reduced. And this slide shows data that we obtained from using Scottish national databases of all women under the age of 40, including children with cancer over a period of time. And we compared them to population-based age-matched controls. And we looked at their chances of having a first pregnancy after cancer. And you can see it was reduced from nearly 40% in the normal population to just over 20%. So nearly halving in the chances of having a baby across all diagnoses. And in this graph here on the left, you can see that split by diagnosis, seeing this really marked effect of cervical cancer, breast, brain, leukemia, and still quite pronounced effects of many of the other common diseases that face young women, lymphomas, colorectal cancers, and indeed, perhaps surprisingly, even thyroid and skin cancers had a lesser chance. And there's much more to it than just biological damage to the reproductive system. Of course, this is all parcel of a broader, the issues of survivorship that our patients face. And maybe some of them will have chosen not to have gone on to have a pregnancy, which they would otherwise have done so. But overall, this shows the impact on the reduced chances. But I'm essentially a biologist, and today we're talking about ovarian tissue. So let's really focus on the ovary. And I think this schematic is quite useful just to highlight the effects of cancer treatments on the ovary that we know about, and actually particularly the variable recovery afterwards. And that's a key aspect of this. So we have this damage from alkylating agents or radiotherapy, damaging particularly the growing follicles, but most importantly, really the non-growing follicles that make up the ovarian reserve that underpin what Meena said in the beginning, that biological clock. And there's damage to blood vessels and stroma as well, so the environment in which the follicles will grow thereafter is changed. And in some women, they will go on to have a full recovery and fertility, or perhaps reduced fertility, and others will have ovarian insufficiency, with infertility and, of course, estrogen deficiency. And picking out which patients are going to go down which of these pathways is, I think, one of the big challenges that we face in fertility preservation, identifying the right women to intervene for and perhaps reassuring those who are going to go on and be able to maintain normal fertility. And of course, there is a big grey area in the middle where we would hope to refine that over the years to come. And a lot of the data underpinning this is based on short-term outcomes such as biological markers such as AMH or menstruation. But of course, what our patients really want to know is the outcomes in terms of fertility, perhaps age at menopause, and for the children, whether they will go through puberty and of course thereafter their fertility and reproductive lifespan. And those outcomes are challenging and difficult because they are so long-term. We also need to remember the uterus and particularly the effects of radiotherapy on the uterus. There's no point having without surrogacy, of course, there's no point having ovaries in terms of helping you have your own pregnancy. But we know that radiotherapy damages the uterus, causes early miscarriage, late miscarriage, right through to premature delivery and postpartum hemorrhage and a whole range of things that those of you who are obstetricians, these are what keeps you out of your beds at night. And perhaps premature delivery is the most robustly demonstrated of this in this meta-analysis we published a couple of years ago with a more than doubling risk in those who had lower abdominal or pelvic radiotherapy. Conversely to the ovary, of course, the other aspect of uterine damage is that the younger you are, the worse it is. So if in the ovary, of course, increasing age is the problem, but here it's younger children who are most at damage. And you can see in this small series we published quite a long time ago now, 20 years ago, you can see that the age at which the girl had had total body irradiation determined her adult ovarian volume, with these young girls having really very, very tiny uteri that will not be able to sustain a pregnancy. So what can we do with it about this? Well, there are a range of options, and I include the males here just by way of recognizing that that's an important field as well. But in the female, we have really, in terms of interventions that will be effective, we have these three options. And of course, today we're focusing on ovarian tissue. And you can see the key aspect of that is that it's appropriate for both prepubertal and, postpubertal women as well. So this has been a field that's been in development now for a number of years. And in fact, if you look at the historic literature, you can find reports of ovarian transplantation going back actually perhaps 130 years or so now. But it was really the work of these two individuals that really brought it into a clinical perspective. And this is Roger Gosden, who was a biologist and was professor of reproductive biology in Edinburgh and subsequently moved to Leeds. And my own mentor and boss for many years, Professor David Baird, who was such a big figure in clinical reproductive medicine. He, at the time when Roger was working in Edinburgh, was developing a model to look at multiple blood sampling from the ovaries, and the animal model he had from that was the sheep. Now, the sheep has a lot of advantage over rodents, which is what Roger Gosden had been most familiar with, because you can do surgical procedures, you can do multiple blood samples, and the overall ovulatory function or ovarian function is much more comparable to the situation in the human with every so often with a monthly cycle, ovulation, although of course a period of seasonal anestrus. So a much more relevant model, and between the two of them, they pioneered this issue of ovarian transplantation. And what they did was they did either an oophorectomy, and then they were able to either freeze cortical tissues from that and replace them on the ovarian pedicle, which you see here. You see these little strips of just ovarian cortex that have been removed and then sewn back onto this pedicle, and they were able to demonstrate that these tissues started working again and resulted in ovulation. So this is an example of the data that they obtained from these pioneering experiments where the ovarian tissue is replaced. There's a period of a number of months before it starts to working. And then you can see here, this is progesterone at the top. You can see these cyclical repeated elevations of progesterone showing ovulation. And the other important line here is the FSH. And you can see here that it was high in this period before the tissue started to work, and then was reduced to some extent while it was working. But it remains actually a little bit elevated, so it isn't generally restored to normal levels following restoration of ovarian function. And they were able to demonstrate that it worked. And importantly, this was a natural conception with no further intervention. And this is the first handsome young lamb that was born from this procedure. So it can work It's a single surgical procedure to take, a single surgical procedure to replace, and then allows restoration of natural fertility. But they also demonstrated another really important aspect of this that persists still, which is the large proportion of follicles that are lost through this process. So when the tissue starts working again, it has already lost perhaps 2/3, even more, of the follicles that were taken from that patient. And that's a really important lesson to learn, I think, that you are not going to be restoring to that patient when you replace her tissue the same as she had pre-treatment. You are losing the great majority of that tissue. So you need to balance that against the damage her ovaries will be incurring, because you will be effectively damaging them yourselves through this surgical approach. So, as I say, a number of very important lessons were learned from that and remain relevant today, such as it works, it allows a restoration of ovarian function. A lot of follicles are lost. There is an increased rate of activation of follicles after this, which may help the ovary start to work again initially, but may reduce its overall longevity. And this suggests there may be some natural inhibitory mechanism. And of course, there's a lot of work involved in identifying that, looking at factors that do that. And those might be really important in terms of controlling that rate of activation and the subsequent length of the life of the ovarian grafts. And David and Roger immediately saw, of course, this had huge clinical application, and this was turned into reality with this first baby that was born in 2004 in Belgium. Jacques Denet was the lead of the team there, and a young woman who'd had a lymphoma, tissue removed and frozen for 7 years and then reimplanted, and she conceived naturally and gave birth to this lovely young baby. So this was the beginning, the first birth from this tissue. And so then immediately there started appearing a lot more thereafter. And indeed, as we heard in the introduction, there are now, there were something like 130, 140 babies born when this paper was published now 3 or 4 years ago. And there are now more than 200, perhaps 250 babies born from this. And there's a review of those live births shortly to be published in Fertility and Sterility, bringing together the groups, the major groups in Europe, in Belgium, Copenhagen, and Spain, that have really done the most work in terms of this over the years. And the conclusion of this review was that this is emerging from being an experimental process to being a valid and effective technique for fertility preservation. But they importantly highlighted the need for careful patient selection for this really to be able to be done safely and effectively. And they used criteria that we had in fact proposed some time before of highlighting the limitations of this to older women, and they thought 35 was a reasonable age limit. It's really for women who've got a good chance of survival and a high risk of losing their own ovarian function from the chemotherapy, generally speaking, that they will have. And we now have a number of guidelines that support fertility preservation more broadly and specifically the use of ovarian tissue. And these go back to 2013 in the UK. There are important ones, American Society of Clinical Oncology. We now have some harmonization of these guidelines. And importantly, last year, ESRE, as was mentioned in the introduction, published this large guideline on female fertility preservation that I had the honor to be chair of. And the European Society for Medical Oncology also produced a guideline on male and female fertility preservation. And ovarian tissue is covered in depth in those papers, and I would highly recommend them. And I'll go over some of the highlights from the ESRE one just now. And indeed, I think perhaps one of the most useful things that we did in this ESRE guideline was identify that this is a long pathway for these patients that needs to be considered from beginning to end at the time that you initiate your interaction with the patients in this regard. And this comes from importance of information provision and helping patients decide what is right for them through assessment of the patient. Then, of course, there is the intervention, what actually happens to them in terms of fertility preservation or not. they undergo their damaging treatment. And then, again, very importantly, the question of assessment for pregnancy, which needs to be part of this whole assessment right at the beginning as well. And particularly when they come to wish to be pregnant, assessment of not only their fertility issues, but associated issues relating to their therapy, whether they had damaging or compromise to their cardiovascular function or respiratory function that may be important in pregnancy. So there's a big picture here to take on board and remember. In terms of actual interventions, this is the equivalent to that chart I showed you earlier from the ESRA guideline, highlighting what can be done, but also raising that in vitro maturation is starting to be talked about in this context, and GnRH agonist protection as well. There's a section on the evidence for and against that. Ovarian transposition may be relevant from our patients. And of course, there may be combinations of these as well. And that's very much a growing field. But as I say, we're particularly going to be highlighting issues regarding this today. And I think one of the things I highlighted when I showed that slide from the review by Donnet and Dolmans was the criterion thinking about assessment of the patient at the time that they present for fertility preservation. And this is a really key part of it. And not a lot of evidence behind it, but we highlighted that patients needed an individual assessment focusing on exactly what's happening to them. It needs to be multidisciplinary. And there may be some women where it's not appropriate, where their ovaries are already damaged. And to highlight, or to give us sort of a checklist for that, we highlighted some of these intrinsic and extrinsic factors, i.e. what's the state of the patient, and then what's going to be done to her. So let's just have a quick look at a couple of those. So when we're looking at the patient herself, there are going to be issues regarding how well she is. Is there a surgical or anesthetic risk relating to a mass in her mediastinum, for example, that could compromise the safety of an anesthetic? Is there an infection or hemorrhagic risk, even from puncturing a stimulated ovary in IVF? Is there a risk of bleeding from that? Because these are, of course, by definition, patients with serious other medical issues going on at the time. Importantly, for ovarian tissue, is there going to be a risk of ovarian malignancy in that ovary from the primary malignancy? There is, of course, the need to obtain consent, and that's very important for the younger patients, addressing that appropriately. There are age limits. I've mentioned an upper age limit, and actually we don't think there is a lower age limit for ovarian tissue cryopreservation. This is something that can be done even on the youngest children and babies. And for the older patients, perhaps some assessment of the ovarian reserve, particularly where they might have received some chemotherapy, some non-particularly damaging therapy beforehand. And that will also assess the likelihood of whether they will need this process altogether. And then, of course, that really brings in that perhaps one of the most important things is what is going to be done to this patient? What is she going to be treated with? Is it going to be a high-risk therapy and we really need to be going all out to help this patient? Or is there a low risk? Or is there an uncertainty? The patient may still be going through the staging procedures at the time you see them, and there may still be uncertainty. And of course, then there is the risk of relapse thereafter as a particular challenge. We've talked about these other issues, such as other drugs, the adriamycin, etc., damaging the heart that might be important for subsequent pregnancy. And then indeed, a key issue is how accessible is this? Has the referral been done sufficiently in a timely way to give you time to do what you want to do and what the patient wants you to do before there is the need to start their anti-cancer therapy? So we have been offering ovarian tissue cryopreservation since the mid-1990s in Edinburgh to a small group of patients, and they are highly selected. And some years ago, we felt we ought to assess our criteria for this, and they were very much, as indicated by the Donnet review, based on very much the risks to the patient and being at high risk and of having ovarian failure, and of course a good risk of surviving their disease. So the question was then, do the patients who've been offered this treatment, are they at end up with a high prevalence of premature ovarian insufficiency? And do the ones that we don't offer it to them, do they end up with a very low prevalence of premature ovarian insufficiency? So we went back over 15 years since we started this to all the patients who we could have offered it to. And the advantage there of our analysis, the rigor of it, was that we had a regional distribution. So we knew all the young women with a cancer diagnosis in Southeast Scotland who could have potentially had this. So we had a proper denominator. And what we were able to show was that, yes, there was a big difference in the cumulative incidence of premature ovarian insufficiency between those we had offered ovarian tissue preservation, most of whom had gone on to have it, and the very low risk in those we had not offered it to, with a hazard ratio of 56, which is pretty remarkable at 10 years. Just recently, we've actually been updating this as a number of years has passed. And this is all young women with cancer under 18, right up to about 18 months or a year or so ago now, assessed a median of 7 years after diagnosis. And we now have some over 400 patients who could have had it. And we've performed this in some 37. Well, we offered it to 37, of whom 26 have had it. And here we have the risk of premature ovarian insufficiency, which is a quarter of them in those who were offered it, and only 3% in those we did not offer it to. And within that 3%, within those very small number, 11 young women, actually half of them had ovarian failure after treatment for relapse, rather than at the primary diagnosis, which is when they were offered or not. So that highlights a number of things, but particularly the challenges of relapse of disease, and then treatment tends to be much more aggressive and much more damaging. So this is the Kaplan-Meier of these, and you can see these widely differing graphs, these lines, with those not offered versus those offered, and a very clear difference between them, justifying these criteria. But overall, I think also these data highlight that the prevalence of premature ovarian failure after childhood cancer is low. It's only about 5%. Only about 1 in 20 girls will have their ovaries immediately and irreparably damaged by their treatments. But that is a good proportion of that is from treatment of recurrence of disease, which is a major concern and issue as to how best to deal with that. So we can store tissue, and this is the laparoscopy on a 7-year-old girl that we did, showing us taking, even at this young age, some ovarian cortex that we are going to freeze. And it has the advantages of being rapid. Potentially when you put it back, you restore ovarian function, and there is no lower age limit. But it is a surgical intervention in girls who are by necessity unwell, and there is the risk of a malignant contamination within that. And there are a lot of issues still to concern, such as how much to remove. Our feeling has largely been to take ovarian cortex, whereas others tend to primarily do an oophorectomy. And this remains a matter for debate at the moment. I think it's important that you are restoring endocrine function in these. Some of these ovarian transplants in the literature have been reported to last for many years, although, and one would assume that that would have advantages for bone density and things like that, although that hasn't actually really been investigated, but certainly a very good theoretical benefit, as well as the option for natural conception. And when we assess this through the ESRA guideline, you can see that here we were able to suggest there was a strong evidence that ovarian tissue cryopreservation should be offered in those who are going to be exposed to moderate or high risk therapy. Other issues had less robust evidence. We highlighted, again, an age issue. We considered it innovative rather than experimental. And we also raised this issue that I'm just going to come back onto in a minute of other conditions outside cancer where young women are going to be experiencing premature ovarian failure. And those might be genetic chromosomal conditions such as Turner syndrome, Fragile X syndrome, perhaps occasionally, and galactosemia, a whole range of other things, as well as non-cancer medical diseases where they are going to be treated with gonadotoxic therapies, such as some of the rheumatological conditions. So how well does it work? Well, the data in the literature remains slightly sporadic, but I think overall, we have a nice report here from the Fertility Protect network in Germany, where they showed that overall, 22% of the patients they replaced tissue in ended up with a successful delivery. And as I say, there is a report in press at the moment in fertility and sterility coming out from across Europe that shows a rather better rate of about 30% of ovarian transplants will result in at least one live birth in those women. It's still far from perfect, but I think at the moment that is the advice we can give to patients. This has not more than roughly a third of patients will be able to have a baby from this procedure. And in this new paper coming out, still slightly more than half of the babies derived from natural conception, with a little bit less, 45 or so percent, coming from IVF. Almost all, of course, are from women who had tissue taken in adulthood, but there is starting to be some literature on those who had it taken in childhood. This was perhaps the first report of that, actually a girl with sickle cell disease who was going to have a bone marrow transplant rather than cancer, but she was able to have the tissue replaced, and indeed she went on to have a natural conception quite a number of years later. There are special considerations with this compared to freezing eggs, of course, and one is the chances of malignant contamination. And patients with leukemia offer a whole range of specific concerns, including how ill they are at the time, but also that this, of course, is circulating disease and therefore risk of malignancy. But there are now case reports where patients have had tissue replaced after leukemia treatment and gone on to successful pregnancy. Very small numbers, very carefully assessed. And you can see this is a young patient with a slightly unusual myeloid rather than ALL. She had a chromosome mutation that allowed for a molecular assessment of contamination. And by a combination of these molecular methods and a xenotransplantation approach, they were able to show as carefully as they could that the tissue was not contaminated and was then replaced and put back. And that is actually important to mention. Of course, that was after initial therapy to reduce the burden of disease rather than when she first presented. Of course, ovarian malignancy ovarian metastases can occur without any degree of expectation. This was one in a patient of ours where she in fact had a Ewing sarcoma in one of her cervical vertebrae, and there was some evidence of that malignancy on the ovarian tissue that we took. So of course we will not be replacing that tissue. For some patient like that, then we think about, well, in vitro maturation, follicle growth, is that the way forward? And there certainly is good progress in that field, but still some way before it can really go forward for actual clinical use. But things are looking promising that things are moving forward in that direction. So what about other medical conditions? Turner syndrome is perhaps the most obvious of these, where many young women will go through ovarian failure, but do have a period of time when their ovaries are working. And this was a series that we published in collaboration with colleagues in Copenhagen and in Melbourne, looking at a total of 15 patients who'd had tissue stored, and then look at that tissue, look at their endocrinology, and were we, in retrospect, possibly doing something useful for these young women. And there are questions as well as the looking at whether they still show normal ovarian function, because we identified that actually quite a few of these show abnormal follicular histology in their ovaries, even when they have apparently a good number of follicles. So this is a 14-year-old with a lot of abnormalities in her follicles in that. Again, a young girl here. You can see these abnormal follicles, damage within early growing follicles that really don't look at all healthy. But yet there are others where the follicular histology was excellent with lots of normal follicles. And we would hope that this sort of tissue would provide these girls with an option. But of course, this is a histological analysis and can therefore only be done after the procedure has actually been completed. So still a lot of issues and questions as to how best to implement that. We are, of course, also only too aware of the challenges of pregnancy in Turner syndrome, with, you can see here, big risks to these patients of hypertensive diseases, sometimes tragic aortic dissection, and you can see a relatively modest 82% resulting in live birth. So a lot of pregnancies put both mother and baby at risk with this condition. So to conclude my talk today, I hope I've discussed with you how ovarian tissue cryopreservation is now an established method of fertility preservation in adults. I think in the children, I still regard it as innovative rather than experimental, perhaps, because there have been such a tiny number of live births in those patients that we still, and I think need to be a little bit cautious and take that very seriously. And there are still some key issues that were actually very much similar to what David and Roger identified all those years ago in their fantastic work in the sheep. And those include how best to protect these follicles and ensure that they survive after transplantation, to maximize that, get away from the only being 30% that survive. Other issues with egg quality. It still seems perhaps surprising to me that although almost all women who have ovarian tissue replaced go on to re-establish ovulatory cycles, but yet barely a third of them achieve a pregnancy and live birth. Why is that? Why is the gap there? What is the problem? Are those oocytes really not quite as good as we think they are? And what's going on there? And you may be familiar with other data that I didn't include in my talk today from oocyte vitrification, where again, there seemed to be a pregnancy deficiency in cancer patients having oocyte vitrification that's not seen in elective oocyte vitrification for non-medical reasons. So something's going on, perhaps with certainly, perhaps just only some of these diagnoses. There is this issue of malignant contamination, and leukemia is perhaps absolutely the most important of that. And there have been very few replacements. People are very cautious as to whether this is an appropriate method at all for these patients, and have serious reservations about that for most of them. And we need to be very careful to select the right patients who need this. And undoubtedly, there are patients who need this, and there are many who don't. And one of the issues relating to that is, of course, the ongoing developments in oncology with the rapid development of new targeted therapies that are going to be introducing different risks to our patients, and that may or may not have important implications for their own subsequent fertility. So, as I say, highlighting risk groups with leukemia. So I want to thank many people who've contributed to the work that I've discussed with you today. Highlight particularly my good friend and colleague, Professor Hamish Wallace, who's a pediatric oncologist. And we've worked so well together over the years to really develop this very challenging area, which is challenging for his colleagues. They are dealing with children with life-threatening illnesses, and then you're thinking of, gosh, another major surgical procedure that may or may not be of value, or may not be put them at risk. So a big challenge for these patients and their carers to take on board. Our laboratory work has been very much in collaboration with Evelyn Telfer, Professor of Reproductive Biology in Edinburgh. And I just wanted again to highlight my colleague, Professor Rod Mitchell, who's a pediatric endocrinologist who leads our prepubertal testicular tissue cryopreservation program. So we are developing this for the boys as well as for the girls. And there have been a whole lot of other clinical colleagues who have been so involved in many of the studies that I've barely had time to touch on with you today. So my thanks again for the invitation. A pleasure to be with you. And I'll be, of course, happy to join in some discussion now. Thank you very much.
Thank you so much, Professor Anderson. Richard, it was a fantastic talk and fascinating research findings that your center has been coming out with, along with clinical service that you offer. Whilst we wait for questions to pop up on the from the audience and the delegates who are listening, I just thought maybe I would start off with one question. Now, you mentioned about ovarian tissue cryopreservation and the risk of POI in those who were offered ovarian tissue cryopreservation versus who were not offered. But I was not clear whether those who did go on to have ovarian tissue cryopreservation, were they at risk of POI subsequently more than those who were offered but did not go for OTC?
So the key question for the research was whether they were offered it or not. And that was the issue, is were we identifying the right patients to offer it to? And within those who were offered, the great majority actually did go ahead. So those data that I showed you are essentially representative of those who had ovarian tissue cryopreservation. There are a small number who didn't go ahead with it after being offered. There were some where the child and their parents decided against it for one reason or another. But they were a small number, but we felt the issue is whether you offer it or not, and then of course most people do take it up. So those data are representative of those who actually have it.
Okay, because what I was wondering was that with ovarian tissue cryopreservation, whether it's ovarian biopsy or removal of a whole ovary, would that contribute to the POI that they were noted to have in subsequent, and that's whether the research data was bit skewed in that regard?
Yeah, well, as an eminent gynecologist yourself, you will know that a unilateral oophorectomy does not increase the risk of POI. But I think it's a really good question. Actually, it's a really important question, and it really underlines that sort of part of our philosophy behind this, which is first to do no harm. That is the first duty of a doctor, isn't it? To do no harm.
Yes.
And so we feel that for many of these patients where, especially in the children, where we know that the overall risk of POI is only 1 in 20, we do not want to be taking more ovary tissue than we need and doing unnecessary interventions that may subsequently compromise their fertility and their reproductive lifespan down the road. So, I must admit, I do find it slightly alarming when you hear data from other centers where they are doing this in large numbers of girls. And I think they're doing it on girls who don't need this. And taking an ovary out from a 12-year-old girl where she doesn't really need it, that is a bad thing. And we know that in women who have a unilateral oophorectomy, but no other damage to their ovaries, we know that does advance the age of the menopause a little bit, actually not very much, maybe only 2 or 3 years. But if you superimpose then all the cancer treatments that they're going to have, then maybe you're reducing their ovarian function to not very much. And if they had 2 ovaries, it would be twice not very much.
Indeed.
So I think that this is a really important issue of the balance between helping our patients and not doing them more harm than necessary.
Thank you.
Richard, one of the reasons, sorry, Meena, to interrupt you.
Yeah, no, fine.
As
Go
I was
ahead.
listening to his lecture very carefully, he stated, and that's what has been reported, the results of the OTC, ovarian tissue cryopreservation, and subsequent pregnancies, the mature oocyte recovery rate and the live birth rate is almost much less than what would be anticipated by the biological markers of ovarian reserve. And one of the reasons, Professor Richard, could be the effect of the cancer disease itself on the oocytes, and that could be undermining their potential to embryogenesis, live birth rate. And I would like to ask you whether the BRCA gene mutation status is being routinely deployed in order to counsel these patients about the subsequent chances of fertility after autotransplantation.
So that is not something that's routinely part of our care. And actually, as the years have gone by, and of course, as you know, oocyte vitrification has really developed over many years. And so increasingly, patients in their 20s who perhaps 20 years ago, when oocyte vitrification was still a little bit less established than it is, would have gone for ovarian tissue. They are now going for oocyte vitrification. So this is increasingly a pediatric and adolescent procedure, I think, and occasionally for adults, but much less commonly. So we really aren't actually, having said that, I was just about to say we hardly ever offer this to breast cancer patients, but actually just recently, just a matter of a couple of months ago, we did have actually a very young girl who was barely 20 who had breast cancer where we offered this. And she had not had a BRCA gene mutation analysis done as far as I know. But that's very much in the hands of the oncologists. But it's certainly an issue because if you were to do this in someone who you knew had that mutation and then replace the tissue, you would also want to be thinking about removing again afterwards, after that patient had gone on to have the child or perhaps children that she wanted. So it would be, a replacement and then a removal again later on. So that would certainly be an important consideration where you have a genetic abnormality there.
Correct. Thank you. Thank you very much.
But I think that for those patients, for the great majority, oocyte vitrification is so very clearly the right way forward for them rather than the ovarian tissue.
Right. Thank you very much.
Richard, there is a question asked by one of the delegates, and she's my suspect trainee. So I'll just go ahead with the question, although I know the answer, but I would like you to answer this. So in the Edinburgh cohort, has any women had the ovarian tissue reimplanted? And if so, what technique was used and what was the outcome? Thank you.
Yeah, so actually the first woman in whom we replaced our tissue, she went on to have a successful pregnancy. So that was fantastic. And so she is a lady who had tissue stored for some 11 years and ovarian failure shortly after her treatment, and then 10 years later she came back married, wanting a baby. And so the procedure that we do, and I think many others do, was to sort of create a raw surface in the ovary with sort of scissors and forceps to open up the ovary, perhaps a bit like opening a pita bread, and then put the tissue in or on it. And it was on it in this because we were able to sort of open it right out. But in others, it's more of making a pocket that you can put the tissue in. We would always preferentially want to replace the tissue on the ovary, but sometimes if you have, for example, a very small ovary or two, I think it's an advantage of only not doing an oophorectomy. You can produce a peritoneal pocket nearby as well that's also successful. And indeed, I heard this talk just yesterday by Mary-Madeline Dolmans, who's put together this bigger European series. And they found that actually the chances of success was just as good in tissue replaced on the ovary as in a peritoneal pocket. I think, to me, it always seems nicer to put it back on the ovary, but it appears that it can, doing a peritoneal pocket is of course, surgically very simple, very straightforward, and still seems to allow same risk, and including natural conception, if you do it, nice and near the tube.
Yes. I mean, I heard about mesosalpingeal implantation of the ovarian tissue. Have you ever done it in Edinburgh, or do you think it's a good alternative to replacing it on the ovarian base?
Yeah, I think, I suspect that's a possibility. I think most people who've done this would think about more of the sort of the pelvic side wall, but certainly within reach of the tube, so to speak. But yeah, you want an area that's going to have a good vascularity and allow it to revascularize the ovary, and I suspect there are a lot of options for that. But I think it is worth just remembering that the replacement in the pelvis does seem to be the most appropriate. And there have been, when the field was in its infancy, people thought, well, you could just replace it anywhere, perhaps even in the forearm. There were experiments where it was just under the skin, and then very nice, easy cutaneous ultrasound monitoring. Just pop a needle in to pick out that egg when it matured. But there have never been any successful pregnancies from that. And only one pregnancy in Melbourne from heterotopic replacement, i.e. outside the pelvis. And that was, I understand, just underneath the peritoneum of the anterior abdominal wall. But most people would definitely think that within the pelvis, to me, close around the ovary is always going to be a best bet.
Thank you. One other question I wanted to ask you is that with ovarian tissue cryopreservation, do you think the way forward would be IVM plus ovarian tissue reimplantation in future, or just ovarian tissue reimplantation?
Yeah, I think that's so in vitro maturation of eggs aspirated from the tissue at the time it's removed, you mean? Yeah. No, I agree. And I think I mentioned when I showed the slide of the various methods that combining them is, I think, the way forward. And that's now, it's not something that we're really able to do, but other centres who are perhaps better organised are able to do. And as I say, I was at this lovely conference organised by the University of Brussels yesterday, and it's certainly been routine for them. They've got a very strong lab set up for in vitro maturation, and but tiny numbers of successful pregnancies. There's really just a few case reports, but it's certainly possible. And if you do a whole oophorectomy, you can sometimes aspirate large numbers of oocytes from the tissue that can then be matured and then frozen. They also described a case where they'd done an IVM on one ovary in vivo, and then a couple of days later, taken ovarian tissue from the other ovary.
Right.
And I think actually it was quite interesting. The discussion was that if they were doing that again, they probably wouldn't do that. And actually, if they'd just done IVM on from aspiration from the two ovaries, they would actually have got, I think it was something like 16 oocytes. They got 8 from the first ovary. And so if they got 16 mature oocytes from the two ovaries without a surgical intervention, that's a great result. But it's challenging. You know, I mean, how many labs in the UK, for example, can do IVM?
Yes.
One.
I know. I mean, the success rate is quite low.
Well, I think the problem is that all our IVF units, or the great majority of them, are so busy just running IVF procedures that they don't have the space and capacity to develop IVM. And it's different, but I can't believe it's too difficult to do, with the right setup and the team and just getting things organized. And it would be great for more clinics to be able to do that, because I think, it's a quick procedure. You don't have that 2 weeks of stimulation that is just a challenge for a lot of our patients when they know it's going to be. That means basically at least 3 weeks from when they're referred to you to when they start chemo. But if they saw you, IVM aspiration, 36 hours later, they're back to the oncologist within 48 hours. Fantastic. So I think that we're really in the field generally. I think we're not doing as good as we could for developing that procedure.
Yeah.
If I was starting my career again, I think I would want to develop that.
Yeah, indeed. I mean, you would probably know that Newcastle is part of the European Commission Horizon 2020 grant funding for germ age, ovarian aging. We were looking at that with Professor Mary Herbert. And in that, I was trying to recover in vitro, immature eggs for in vitro maturation to assess whether the chromosome segregation is affected by in vitro matured compared to mature eggs and the different stages. So I did find it quite challenging sometimes to get sufficient number of in vitro immature eggs from unstimulated ovaries, which we could go on to study and develop and compare it to Met2 eggs that we get.
No, it is definitely, I agree, it is different skills. But you may be aware of a recent trial from Vietnam, an RCT, that in good responders in IVF showed non-inferiority of live birth rates from IVM versus conventional IVF. Now, that was in good responders, but it's an amazing finding.
Indeed. Very, very interesting. So you mentioned, Richard, that ovarian tissue cryopreservation is now should be regarded as an established technique, as well as the ESHRE.
Well, in the ESHRE guideline, we described it as innovative rather than established, but let's get it there. Yeah.
So do you think more centers, like in UK currently, 2 centers, Edinburgh and Oxford, are commissioned, or they do ovarian tissue cryopreservation, but there are several IVF units. Do you think other centers should take it up, or should it be centrally commissioned all across India and everywhere else? Should more people just take it on, or it should be a specialized service for certain centers?
I don't think you need to do it in terribly many centres, actually. I suspect they're but I think one for the whole of England and Wales is probably inadequate. But, I think as I say, this has increasingly become a procedure for children and adolescents. and not for adult women who should, in the majority, I think, be having oocyte vitrification with or without IVM or something like that. So I think we are talking about a small patient population of children, young adults or adolescents who are, a challenging group to be looking after, and there are possibilities, of course, transporting ovarian tissue, and that's something that particularly the Fertility Protect network in Germany has really demonstrated that can be done very successfully. I mean, I think our model in Edinburgh is becoming a little dated, actually, because we've always very much taken the view that the patient should come and see us because we're doing it as a research protocol and we want to know we're doing this on the right patients. But I think as it's becoming more established, it's becoming more appropriate for the patient just to have the surgical procedure locally and to be able to transport the tissue to a central freezing bank. And that then becomes involvement of a lot more people around actually involved and doing part of the procedure. And then it just needs to go to one tissue bank to store it. And that makes sense to do that. Running a tissue bank is a really complicated business, and not everywhere needs to do that. But in Newcastle, you could certainly be doing the surgical procedures and transporting the tissue. Maybe there would be a northern hub in Manchester, for example, that would cover a huge geography and number of patients, and you'd have 2 or 3 of those around the UK.
Right. Thank you.
In India, we have some centers who have started doing these procedures, and very few, I would say. And the ovarian tissue is being cryopreserved with the careful counseling, careful selection, all the criteria being taken into consideration. However, we are waiting for the results of the autotransplantation and the success thereof, because the procedure is still in its very early nascency, I would say, and the tissue is being cryopreserved, but not being auto-transplanted yet. Yeah. One of the important issues here is the contamination of the ovary with hematological malignancies. Yeah. And that is the place where you have the patient is on the operation table and you have sectioned the ovary, and you can cryopreserve, and then you can go on with the IVM so as not to replant or auto-transplant the same piece of the ovary, but grow sides out of it. And that can reduce or alleviate the chances of reintroduction of an occult malignancy from that ovary.
Yeah, I absolutely agree. I think that adds to the process, doesn't it? And I think for where you do have these hematological malignancies, I think there's a real concern over that.
Right.
Thank you so much.
If you're offering this to 10-year-old girls, it's going to be a long time till they come back and want to have a baby.
Absolutely.
Well, you hope it will be anyway.
Yeah, absolutely. True. Fantastic talk.
Enjoy your talk. Yeah, thank you so much. I was just thinking as a parting message to all the listeners and viewers, especially because we have a lot of younger early career clinicians and technicians and embryologists on the delegation today. So from your life lessons to your journey to reaching this stage of fertility preservation, what would be your key messages, even whether it's professional development or fertility related, anything that you would like to give them?
Well, I think related to this, I think that we are now at the stage we do have a technique that can be used, and as we've heard that in India it's maybe still in its infancy, and there's certainly a huge amount that can be done with this technique that is now becoming better understood. And a lot of patients are not actually getting access to it. And that has surely got to be getting access for the right patients to have the right procedure is the key thing here. And for some patients, this will be the right procedure. There aren't a huge number of them, I don't think. But, in a place the size of India, it's a lot of young women who need this.
Right. Thank you very much.
Thank you. So I think the most important thing would be to network and collaborate with the oncologists to spread the awareness amongst them, so they refer the young girls at the right time so that this can be done.
It's a bit like the old saying is it takes a village to bring up a child. It takes a lot of people to organize a successful process for this, right through from the oncologist being happy to refer them, the fertility team, the lab team, the tissue bank who are going to be doing that. And of course, then, it has to be with a view to very long-term care over perhaps decades before these patients come back and see us again. So it's a very much a teamwork approach.
Right.
Yes.
Absolutely. Agree.
Thank you so much. I'll pass it on to the organizers if you wanted to say the last word. Thank you so much, Richard.
Thank you.
Thank you so much, ma'am. Thank you very much.
Wonderful talk.
So actually, it's a very wonderful session. We can see the viewers have really enjoyed Dr. Anderson, Professor Anderson. And we thank you on behalf of AmCure for sparing your valuable evening for us, valuable afternoon for us. And thank you, Dr. Meenakshi Chaudhary, ma'am. Thank you, Rajan Vaidya, sir, for the wonderful event today. So thanks on behalf of AmCure. We really thrilled to see the wonderful scientific talk today, sir. Thank you very much.
Thank you.
Thank you. Thank you. It's been a pleasure.
We'll be looking forward for more
Same here.
sessions. Thanks.
Bye-bye.
Thanks. Bye.
Bye. See you again.